This section of the shockroom orientation class is going to be about titrating critical medications in the emergency room. So what does our quality department audit? They will check to see if the medication was started at the ordered dose. Was the medication titrated according to the doctor's order? Was there supporting documentation and was it completed according to the goal? And did the physician include all the medication instructions in the comments? Before medication administration, we should check for order completion. What should a complete titratable medication order have? It should have a medication name, the starting dose, the unit dose, titration parameter, therapeutic physiological goal, a maximum dose, titration increment, a titration frequency, and a notification of the qualified licensed personnel. Remember, if the titratable medication order on the MAR is incomplete or inaccurate, do not document on it. Get the ordering physician to modify the order. This is an example of a complete titratable medication order. If you look up top, it has a medication name and a unit dose of fentanyl. On the right, it shows you the starting dose, which is 25 mics per hour, a titration frequency, which is to titrate every 5 minutes, a titration increment, which says to titrate by 25 mics per hour, the goal, which is mild pain, and when to notify the provider. So what is wrong in this scenario? Take your time to take a closer look. Okay, first, the actions on the second and third boxes should say rate dose change. Second, the medication was titrated by 5 minutes instead of 10 minutes like the order says. Third, the medication was titrated up too high by 50 mics per hour instead of by 25 mics per hour. Fourth, the RAS score showed that up-titrating the medication was inappropriate when the patient was more sedated and at goal. Lastly, there was no supporting documentation at 1350. Titration during patient emergency. In situations where the patient's condition is critical and the physician asks you to titrate or initiate the medication at a specific dose or rate that falls outside the ordered parameters, the following conditions must apply. First, the qualified licensed personnel must be at the bedside to give the orders until the therapeutic goal is achieved. And then once the goal is achieved, the qualified licensed personnel will write the order to match the latest setting. And then the nurse must document each titration up or down with the supporting documentation, and on the comment box, a statement affirming the presence of the qualified licensed personnel at the bedside. So, for example, in the comment boxes, you should document titrated per Dr. Smith at bedside for patient emergency. And then when the map of greater than or equal to 65 is reached, Dr. Smith should discontinue the previous order and then place another order to match the current setting. When it comes to double dosing with titratable medications, the nurse must still always follow the titration rate and dose as it was ordered. In situations when it is necessary to titrate faster to achieve a therapeutic goal, the nurse may use double dosing with the following conditions. First, a dose has been titrated twice and therapeutic goal was not achieved. Second, dose can be doubled, but not to exceed the maximum ordered dose. And third, double dosing must be part of the order instruction for the medication ordered by the doctor. This is an example of what the order looks like with a double dosing order included in the comments. And double dosing is only applicable for 3 particular medications: the norepinephrine, epinephrine, and phenylephrine. This is an example of double dosing for norepinephrine. As you can see, at the first and second titration, the goal map of above 60 has not been met. So, the third titration dose was doubled and will be continued until the therapeutic goal of MAP above 60 is reached. In this example, again, after not reaching the MAP goal of above 60 after the first and second titration, the succeeding two titrations were double dosed while still following the titration frequency. The titration was stopped at 12:12 when the MAP reached 65, but at 12:14 and 12:16, the MAP went below 60 again, and so the titration was resumed per the original order. And then, at 12:18, after 2 doses, the MAP was still below 60, and so double dosing was done during this time, and will continue until the goal is reached. Here are some key points to remember. When a critically ill patient requires frequent medication titration changes as life-saving measures, the nurse must stay to continue to monitor the patient closely until the patient becomes stable and the physiological goal is achieved. If you need time to intervene and closely monitor your patient, notify your shock room lead or your charge nurse to make the necessary arrangements. Let's practice within our nursing scope. Medication orders need to be followed precisely. Anything done outside the order parameters is considered practicing outside of the scope of your nursing license. And that is the end of this presentation. Feel free to reach out to your leadership if you have any further questions. Good luck!